Hello, and welcome to webinar number 10 of the COVID-19 webinars of New York Medical College and the Touro College and University System. I am once again your host, Dr. Edward Halperin, the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. Yes, COVID webinar number 10. This is 13 months since we first had our COVID-19 continuing medical education program. And we keep hoping time after time that we'll be done, but there is still clearly no end in sight. So we will do what we have been doing, which is strive to give you the most up-to-date information to help you in navigating the pandemic, and for those of you who are healthcare practitioners, helping you provide the best possible care to your patients. We have, once again, some old friends and some new friends for our program today. But first, I am sorry to report that we will not be joined, as described in the publicity for today's program, by Drs. Shirlita and Robert Amler. It is with great sorrow that we report the death of Dr. Robert Amler's father, Dr. Melvin Amler, well-known Westchester dentist. We express our condolences to the Amler family. May they be comforted among all those who mourn in Zion and Jerusalem, and may his memory be for a blessing. We will carry on with our other panelists. We are joined today by Professor Chandra Shekhar Bakshi, Professor Kathleen DiCaprio, Professor Denise Tahara, Professor John Pellicone, and Professor Renee Garrick. They're going to teach us about what we need to know about the basic science of the mutation of the virus, the clinical aspects of viral mutation and how that affects vaccination. Dr. Tahara is going to educate us about food insecurity during the pandemic. And then there'll be a panel discussion, which I will host with Drs. Pellicone and Garrick, about how one manages a mass vaccination program and what we've learned from the process. And there'll be time for your questions and answers. So don't hesitate to type your questions in on the question function on the bottom of your screen. I will appear later in the program to tell you all about how to get your CME credit for those of you who want continuing medical education credit, and how to make a donation to support these programs if you're so inclined. Thanks for joining us. Welcome to our program. And let's begin with Professor Bakshi.
Good afternoon, everyone, and thanks for joining today. My name is Chandrasekhar Bakshi, and I am an associate professor of microbiology and immunology at New York Medical College. So of the several challenges that we have faced in the last year due to this COVID-19 pandemic, which is caused by SARS-CoV-2, the recent and more concerning one is that this virus is mutating. So in today's presentation, what I'm going to do is I'm going to address two important questions. So the first one is, how does SARS-CoV-2 mutate? And what are the consequences of this mutation? I have no conflicts to declare. So let's first start understanding the mechanism that how SARS-CoV-2 mutate. And this is the replication cycle of the SARS-CoV-2 virus, which is an RNA virus. So this SARS-CoV-2 virus, via its spike protein, it binds to this ACE2 receptor, which is present on our cells. The virus gets into the cell, the RNA genome is released, and then it is recognized by our host cell machinery, which makes the proteins and sets the stage for the viral replication. So at this stage, most of the mutations are introduced because when the virus is replicating. And this is because, as it's shown here, that the SARS-CoV-2 RNA, this is the sequence, is copied by an enzyme called RNA polymerase. And this RNA polymerase is an error-prone enzyme, and which is responsible for introducing a lot of mutations when the virus is replicating at a very rapid rate. But SARS-CoV-2 also has another enzyme which has proofreading activity, so it can correct the errors that are caused by RNA polymerase. So normally what happens is the virus, the viral RNA is copied, it's translated, and then it's assembled, and then it's released. So majority of the time, no mutations are introduced. And because of this exonuclease, the frequency of mutation in SARS-CoV-2 are way less as compared to other RNA viruses. However, when the virus is replicating very rapidly, even with this proofreading enzyme, the errors are introduced by the RNA polymerase. And this results in the substitution of the nucleotides as well as the substitutions of the amino acid, which makes different proteins. And these together, what we call as a variant, because the variant will have an inherited set of distinctive mutations that provide a different phenotype to the virus in terms of its transmissibility, virulence, or antigenicity. So at the end of each replication cycle, will have a mixed population, and the virus which is more fit to survive or transmit will be naturally selected in the subsequent rounds of transmission. And this is how the variants will predominate, because if they have better capability to transmit, survive, or cause virulence are selected as opposed to those which initiated the infection. So the first variant that we knew of SARS-CoV-2 emerged in March of 2020. That was 3 months after the onset of pandemic. And this variant had one mutation in its spike protein. So this one amino acid substitution from asparagine to glycine. And this caused improved binding of this variant to human ACE2 receptor. And as a result, the patients, those who are infected with this variant, had high viral loads in their upper respiratory tract. However, the disease severity was not infected. And this variant predominated quickly, as it's shown in this map, because like this is where it started, and by June, as you can see that the majority of the variant, which is in blue, predominated all over the world. And now this is responsible for 99% of the cases. So another variant which is in news right now is this UK variant. It's called B117 lineage. And this is a variant of concern. That's because it spread very rapidly from UK to 70 other countries, including United States and Canada. And this variant has about 40% higher transmissibility rate as compared to its parent. And this has also resulted in about 6 to 8-fold increase in the number of cases. It is also believed that this variant is more virulent, but again, these claims are not substantiated. And at present, there is no evidence to show that this virus can escape the vaccine or infection-induced immune response. So these are some of the mutations that have occurred in this particular variant. As you can see, that majority of these mutations are concentrated in the spike protein, and these three specific mutation, and one specifically in this RBD domain, or the receptor binding domain, which is the one which is responsible for binding to the ACE2 receptor, is believed to have increased its transmissibility or virulence. The second variant that is again in circulation at the moment is South African variant. We call it B1351 variant. And this is the predominant strain variant right now in South Africa. This is again like UK variant, has increased transmissibility, but there is no evidence of its increased virulence. However, the concern is that this variant can escape the immune response, which is generated in response either to the antibodies as a result of infection or vaccination. So if we see that what mutations have accumulated in this particular variant, as you can see that this majority of these are concentrated in the spike protein of the SARS-CoV-2 of this variant. So this one mutation which is present in the UK variant is there, but in addition to that, it has also acquired 2 more mutations in the receptor binding domain. So as a result, it has not only enhanced its transmissibility, but this one particular mutation, this E484K, is believed that this may allow this variant to escape from the antibody-mediated immune responses following vaccination or infection. So the third variant is called the P1 or B1351 lineage. It's a Brazilian variant because this was first isolated or identified in Japan from travelers from Brazil. And now this has been reported from 22 countries, with local transmission reported from Brazil and France. But we do not know much about the transmissibility and virulence of this variant at the moment. But like South African variant, because it carries the same mutations in the similar locations in the receptor binding domain of spike protein, it is believed that this mutant may also escape the immune responses. And then these are the three different types of variants which have been identified in the United States in last 1.5 months. So these are identified in California, Ohio, Louisiana, New Mexico, as well as in other parts. But again, they have the major theme going that like majority of the mutations are in the spike protein. So the spike protein appears to be a major target for the mutations that has changed the phenotype or the transmissibility of the virus. So, and this mutation in the spike protein are a cause for concern. But again, I would like to mention here that right now, from the data that are available, we know only half the story, because there are two very important questions that yet to be answered. The first thing is, like, what is the status of innate immune response against these variants of spike protein? Because innate immune response plays a very important role in protection against COVID-19. And also, we do not know the contribution of the T-cell mediated response, because right now all the focus is being, all the attention is being focused on the neutralizing antibodies, which are generated in response to either natural infection or vaccine. Thank you so much for your attention, and I will stop here.
Hello again, this is your host, Dr. Edward Halperin. I'm sure that many of you want to know the details of how to get your continuing medical education credit. We've gone very high tech this time around, and we have 3 options for you in order to get your CME credit. You can use a text message and send a text message to 828-295-1144 and type in 39HYPE, all in capitals, 39 hype, and you'll get a text message back telling you how to get your CME credit and how to fill out your satisfaction questionnaire. Or you can go to our website, www.eeds.com, click the sign in button, enter that same code, 39 hype, HYPE, and once again, you'll get instructions as to how to get your CME credit or how to fill out the satisfaction questionnaire. And our new feature is if you want to whip out your electronic device and scan that QR code with your app, it'll do the same thing. It'll take you to the site to get your CME credit and to fill out your satisfaction questionnaire. Now, we're only going to make this announcement twice in today's program, so take a screenshot, write it down, take a photo, or make an image of that QR code so you can get your CME credit. And remember, if you have questions for any of our panelists, please type your question in the Q&A function on your screen, and we'll be monitoring them. Now back to our program.
Hello, my name is Kathleen DiCaprio, and I'm an assistant professor of microbiology and immunology at Touro College of Osteopathic Medicine, Harlem campus. Today, I will be presenting an update on COVID-19 vaccines, as well as to discuss the effects of emerging virus variants on vaccination plans. I have no conflicts of interest to declare. So, around this time last year, we were all hearing about a new respiratory virus, later to be identified as SARS-CoV-2, the cause of COVID-19. Now, although much progress has been made in vaccine developments, with several of them demonstrating life-saving immunity, the emergence of virus variants challenges our scientific and medical communities. In this presentation, I will review some of the more concerning emerging variants, as well as provide an update on COVID-19 vaccines and how some of these vaccines are addressing these variants. Now, multiple SARS-CoV-2 variants are circulating globally. 3 emerging variants include the B.1.1.7 UK variant, the B.1.3.5.1, the South Africa variant, and P.1, the Brazil variant. All 3 of these appear to have increased transmissibility, with some experts suggesting that the UK variant may be associated with an increased risk of death. Although more data is needed to confirm, there is much research aimed at understanding these variants better. Now, Although some information about these variants is known, for example, as I mentioned, there's some information on transmissibility that's available, there's still gaps in knowledge about these as it relates to their pathogenesis and whether or not they produce a different clinical disease compared to other variants. Furthermore, and what we'll be talking about and focusing on in this presentation is whether or not the currently available vaccines work against these variants. Now, as of right now, there are no recommendations to change the vaccination plans. The goals are really to get as many people vaccinated for as much protection against severe disease and death as possible. However, concerns of these emerging variants are not being ignored, and appropriate entities are preparing and assessing how to best approach these. Some are looking at possibly adapting vaccines to better target variants and or adding a booster to a specific variant. So at this point, these activities are still really early in discussion and exploration. But first, we really need more information on the efficacy of the existing vaccines against these variants. Indeed, some recent vaccine data has been released. So let's take a look at this. Right now, there are 2 vaccines that are approved for use in the US under an emergency use authorization, or an EUA. Both of these vaccines had data accompanying their EUA that included 90 to 95% protection against COVID-19. These are the vaccines many of us have already received. So, what do we know so far about how well these vaccines protect against the variants? Well, data from Moderna shows that their vaccine delivers equivalent levels of neutralizing antibodies against the UK variant, but a 6-fold reduction in neutralizing titers against the South African variant. Now, Moderna did emphasize, though, that despite this reduction, neutralizing antibody titers remain above levels that are expected to be protected. Now, while the current 2-dose regimen still holds so far, the company is exploring the inclusion of a 3rd shot or a variant-specific booster as a means to generate a more specific immune response. Now, the Pfizer-BioNTech vaccine showed a less than 2-fold reduction in antibody titer levels. However, in their assessments, they used an engineered virus with 3 key mutations from the South African variant. So these findings are a bit limited because it doesn't look at the full set of mutations. So we're going to have to wait and see what some of their data comes out later. There are 3 noteworthy vaccines that are active in phase 3 trials right now, but which are not yet available for use. Now, the Johnson & Johnson vaccine, which has been in the news a lot lately, is a single-dose adenovirus vector vaccine that can be stored at refrigerator temperatures. Now, they recently released data demonstrating 72% efficacy in its US trials and 66% effective overall at preventing moderate to severe COVID-19. Particular importance is that this vaccine showed protection against severe disease caused by the South African variant. And they recently submitted an EUA request. AstraZeneca, which has received approval for emergency use in the UK, is currently in phase 3 in the US, with projected data to be ready for an EUA request around April. For the trials in the UK and Brazil, this vaccine showed 62 to 90% efficacy, depending on the doses that they use. So they used a couple different doses, which is why they have such a spread in efficacy. Now, the Novavax recently released interim data that its 2-dose vaccine is 89% effective from its trials conducted in the UK, and they plan to request an EUA in the UK soon. Now, although the Novavax vaccine, which is a subunit vaccine that expresses the full-length spike protein, they only recently started their phase 3 trial in the US, the data from the UK trial is particularly promising because it showed good protections against both the UK and South African variants. Now, this past year has introduced many of us to a new normal. For many, there's been sadness, grief, exhaustion, anxiety, but also strength, courage, and resilience. The impressive efforts and outcomes of medicine and science have brought us to today, where millions of people have and millions more will receive potential life-saving vaccines. For many, a return to normal or close to it is around the corner. But for some, whether you like it or not. Thank you.
While we are proud to present this webinar as a free program with free continuing medical education credit, it of course costs time and money to put these programs on. We hope that many of you will consider helping support these programs by making a tax-deductible gift to help offset our costs. Great things are happening at New York Medical College. We hope you're willing to be a part of it. The choices for making a donation are to phone our development office at 914-594-2720, and they'll be happy to take the information. If you'd like to do it online, go to our fundraising website, www.nymc.edu/give, and do it online. And if you'd like to write a good old-fashioned check and put it in the US mail, it can be sent to the New York Medical College Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Please put on the note part of the check that this is to support the COVID-19 webinar, and we'll be more than happy to accept it in that way. Now, remember, if you have questions for our speakers during today's program, use that question function on the bottom and type them in. And now, let's return to our program.
Hi, I'm Denise Touro. Welcome, everyone. I've been asked to speak with you today about an epidemic that precedes the pandemic, food insecurity, and how the pandemic has exacerbated this crisis. I have no conflicts of interest to declare. Food insecurity has been a public health crisis for years. Images of long lines of people in cars are everywhere, bringing some much needed attention to this crisis. So what do we know? Prior to the pandemic, over 37 million Americans were food insecure, including over 11 million children. In 2020, it is estimated that over 54 million Americans were food insecure, including almost 14 million children. Minority communities are disproportionately affected. So what is food insecurity? What has contributed to the increase, and what can we do as physicians? So that everyone's on the same page, we know that food insecurity is when there is uncertain and inconsistent access to inadequate amounts of nutrient-rich food. Hunger is physiological. You can be both hungry and food insecure. We know there is much research that describes the impact of food insecurity on chronic diseases. There are disruptions in the food supply chain on both the supply side and the demand side due to COVID-19. These include outbreaks on farms and food processing plants, unemployment, restaurant closures, and donors who are now recipients. Looking at the data in New York, we see that about 7.8 million households are food insecure, a prevalence of about 10.8%. Disparities exist. In the chart on the left, refer to the disproportionately higher levels of food scarcity among Blacks and Hispanics. In the chart on the right, note the two top lines, which reflect those who are food insecure due to loss of income. In red, the top line, and blue, the line below it, who are food insecure and receive or should receive stimulus checks. Large percentage of these people are receiving the checks, are using them for rent and or food. Social determinants of health drive food insecurity, which impacts chronic diseases, which widens the disparities. In 2020, between 17 and 25% of Hispanic New Yorkers and 15 to 22% of Black New Yorkers experienced household food scarcity. These percentages were 3 to 4 times higher than among white New Yorkers. Further, consider the impact on health and well-being of two comorbidities of obesity and cardiovascular disease. Layer on zip code, and we see the effect of the confluence of social determinants of health factors. With high rates of obesity among Black, Latinx, and Native American populations, and the accompanying multiple morbidities, higher mortality rates among these populations should not be a surprise. However, as physicians, there are strategies we can employ to bend the trajectory. Social determinants of health are factors and conditions in the places we live, work, learn, and play that impact our quality of life and health outcome. The CDC has categorized these factors into 5 groups. And what we know is that there is an additive effect of these factors in each of these categories. With regard to COVID-19, here's how they're amplified. In neighborhoods, there are folks living in crowded living conditions, food deserts, and food swamps. There's limited access to usual source of care, lack of access to healthy foods, resulting in calorie-dense versus nutrient-rich diets. Higher prevalence of obesity and chronic diseases result in increased mortality from COVID-19 in disadvantaged populations. There are geographical and cultural factors and economic instability, where these folks have an inability to work from home and there's loss of jobs. Families are suffering financial hardships. They are making trade-offs they should not have to make. They recognize the value of stable housing and then make choices, rent and utilities versus food. There are families who are skipping meals, and where school meal programs are not meeting the increased needs of families, parents will go without eating. Families trade off with cheaper alternatives, nutrient-poor foods, and become dependent on soup kitchens and food pantries and what is provided through the schools. It's not enough. Remember, food insecurity is invisible, so be vigilant and diligent. At each encounter, ask 2 questions. We worried whether our food would run out before we got enough money to buy more. The food that we bought just didn't last, and we did not have the money to get more. Based on the responses, take action. Here are some things that you can do within your practices. At every health encounter, whether a televisit or in person, screen for food insecurity and social determinants of health that interfere with patient adherence to treatment plans. Record the biometrics, connect patients to resources, and follow up. Identify gaps in care and create smooth patient handoffs and follow up. Many patients, especially seniors, do not realize that they qualify for some of the food assistance programs. Help them connect and enroll. The guide here listed is a guide prepared by New York City for all 5 counties in New York. Most county health departments have similar guides. Food pantries serve food to families who may or may not qualify for SNAP, so it's really important we get this information out. Share the information with patients through your portals, or for those who are on the other side of the digital divide, have printed materials with plenty of visuals. The benefit of diet and lifestyle choices can be traced back to Hippocrates. You are the community influencers and you have the trust of your patients. Identify opportunities, collaborate, and partner with feeding networks in your community. Co-locate. These programs need to be championed by the medical community. The cost of supporting food prescription programs are far less than the cost and strain on the healthcare system when these folks present in the ED. So this is how we vision the journey for food security. We start with intake, where we do the screenings, do the assessments, including the biometrics, our treatment, which is our food prescriptions, utilization, food pharmacies, congregate meal settings, delivery options, and evaluation. So we need to close the loop. Lastly is normalization. This is the new way we treat our patients. Food prescriptions, electronic health records, food benefit accounts, all connect to improve the health of our communities. Thank you very much for your time. Here are my references.
Hello again, this is your host, Dr. Edward Halperin. I'm sure that many of you want to know the details of how to get your continuing medical education credit. You can use a text message and send a text message to 828-295-1144 and type in 39HYPE, all in capitals, 39 HYPE, and you'll get a text message back telling you how to get your CME credit and how to fill out your satisfaction questionnaire. Or you can go to our website, www.eeds.com, click the sign-in button, enter that same code, 39 HYPE, H-Y-P-E, and once again, you'll get instructions as to how to get your CME credit or how to fill out the satisfaction questionnaire. If you want to whip out your electronic device and scan that QR code with your app, it'll do the same thing. It'll take you to the site to get your CME credit and to fill out your satisfaction questionnaire. And remember, if you have questions for any of our panelists, please type your question in the Q&A function on your screen, and we'll be monitoring them. Now back to our program. Welcome to our next part of our webinar, where we're going to have a chat about what I learned and what I didn't wish I learned about how to manage a mass vaccination campaign during a pandemic. As I remarked in the opening to our webinar today, we will not be joined by Dr. Sherlita Amler, who was to participate in this panel discussion, but we have our two other panelists with us to join us in this conversation. So I am once again your host, Edward Halperin, the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. And let's ask our two panelists now to introduce ourselves in alphabetical order. First, Dr. Renee Garrick will tell us who she is and what she does, and then Dr. John Pellicone. Dr. Garrick.
Hi, I'm Renee Garrick, and I'm the Chief Medical Officer and Vice Dean at New York Medical College and Westchester Medical Center, and have been helping to oversee the COVID initiative since its beginning back in April of 2020.
And I'm Dr. John Pellicone. I am the Chief Medical Officer at Metropolitan Hospital in New York City and the Associate Dean of Education at New York Medical College. I've also been overseeing the process here since last March.
Well, thanks both of you for joining us in this conversation. Let's begin our chat by assuming that we've both all come back from retirement, and it's the year 2040. And we're seated before a big audience of earnest young medical students and MPH students. And they want to hear us tell war stories of the great pandemic of 2020, 2021. And there in the third row, a earnest student raises her hand and she says, Dr. Pellicone, if I was going to face a pandemic like you did back in those olden days, what's the most important lesson you learned about the right way to run a mass vaccination program that I, as a young student, ought to know now? What was the great lesson of 2020, 2021 in running a vaccination program? What would you tell her?
So with regard to the process and getting people moved through as effectively as possible, especially if we're doing it at local facilities, number one, I would make the registration process as rapid and as brief as possible, maybe limiting it to name, date of birth, and possibly one other metric such as ethnicity. I would anticipate the need for supplies. We seem to take for granted sometimes that needles, syringes, alcohol swabs, and gauze are in unlimited supply. And when a mass vaccination program is necessary, that is not always the case. And then the third lesson we learned from the Disney people, the space that you choose must have separate entrance and egress areas. The people must enter from one area, be vaccinated, have their waiting time, and then exit from a completely separate area so that the flow of traffic is smooth.
It's a very, very important point. One of the more peculiar books I read when I was in business school was called Queuing Theory, the theory of lines. It's not something that we often pay attention to, but there's a whole science to how to create lines, which, as you said, Disney mastered long before others. Well, not to be outdone, Dr. Garrick, you're at the same class as 2040, but of course you don't look a day older than you do now. And a medical student, not to be outdone, says, well, if we were going to face a pandemic like you did back in olden days, what's the most important thing you learned that we should not repeat running a mass vaccination program? What's the biggest mistake or biggest error that you learned that I don't have to go through? What would you tell them?
So from my perspective, I think the biggest problem that we have had nationwide has been that we haven't had a nationwide initiative, and that every state's different, every area has been different, and the rules and the complexity of those rules, I think, have sometimes gotten in the way of us being as efficient as we could have been, so that the ability for somebody to understand what it took to get a vaccination has been very complex. And we've had lots of different staging groups, and those groups required certification and evidence of eligibility. And I think that that complexity of that system has been very challenging for many people. And I think the variation from state to state has made this a very complex undertaking. It's a federal problem. We are suffering from this pandemic nationwide. And I think we would have been better off, to our young colleagues now in the year 2040, had we approached this from a national position and maybe engaged National Guardsmen and other groups to help us from the get-go, and thought about the planning of the vaccine and the arrival of that vaccine early on, like last summer, rather than much later when it actually finally arrived. And I shouldn't say finally arrived, because honestly, I think it was a tour de force of science to get this vaccine out as quickly as we did. And I think we should have matched that with our planning efforts early on as well.
And so the student says to you, you know, Dr. Garrick, I read in a history book about the history of public health that it says that decentralized authority is good for a laissez-faire economy, but it's lousy for dealing with a public health emergency. Is that the way you'd summarize it?
Yeah, I think that it could have been centralized from the global perspective of how we were going to do it. I think that in some states, in some areas, local health departments were very well situated to handle this, the inoculation, and to handle the planning around it. In some more rural areas, they might have needed the help of larger parts of the state. But I do think by having it done, that every state has done it differently, areas of state have done it differently, that it has really added to the complexity. And for places like New York, where people live in the surrounding states or work in New York, but live in New Jersey, it's become very complicated and very confusing. And I think there has been a lot we can learn about this concept of having a more national approach when something is affecting the entire country, as this has.
Well, the question then turns now to Dr. Pellicone from our hypothetical class 20 years hence. And of course, to be complete, Dr. Pellicone and I don't look a day older either in 2040. Dr. Pellicone, feeding off on what Dr. Garrick said, another student says, you know, I was doing research in preparation for today's class, and I read about the different speed with which people got vaccinated in West Virginia versus New York, and Colorado versus New York. And of course, they said there was a difference among the 50 states, but there's 53 states now, I know that. But do you think that was a key, what Dr. Garrick said, that it should have been better being centralized, or was it better that one size didn't fit all and different states somehow did it differently? And maybe that was an argument for so-called federalism, decentralized authority.
So I emphatically agree with Dr. Garrick. This needs to be a true national program organized either by the military or the National Guard. However, it must be done free of all red and blue politics. I believe that the local authorities, the states and the cities should provide the sites where the vaccine is given, and the military and or the National Guard should organize and direct the flow. And of course, there should be no charge for the vaccine in the setting of a national emergency. And although it is important to vaccinate the vulnerable, such as the folks in the nursing homes, we can't forget that you have to vaccinate the vaccinators first, and you have to vaccinate the people that take direct care of the patients. Because when they go down, we have the kind of problems that we faced last spring inside hospitals.
All right, let's turn to another aspect of this. Yet one final student in the class says to Renee Garrick, they used to talk about something called vaccine resistance, and some people talk about vaccine hesitancy. What'd you call it when people just said, I don't want to be vaccinated? And what did you do about it? What did you learn in that era?
So I think that's really critical. And I think Dr. Pellicone touched on one of the reasons. And I believe that some of this vaccine hesitancy, which was the term that we used, part of it did stem because the entire COVID epidemic became a political football. People didn't believe it existed. People didn't want to wear masks. When you look back on this from your vantage point now, years later, you'll be shocked by what went on. And I think that the vaccine hesitancy in part arose because of that. And what we tried to do, so in fact, some of the surveys done suggested the vaccine hesitancy in some populations was over 50%. And within healthcare providers, it was as high as 30% in some polls, meaning that even though the vaccine was available, people said, I will not take it. And either they didn't take it because they didn't trust the science, or they didn't take it because they think it had been politicized, or they didn't take it because they didn't trust their physicians, which is the case for some socioeconomic groups. So what we did in our organization is we actually went floor by floor and identified everyone who was at risk, as Dr. Pellicone mentioned, anybody who came into contact with patients with COVID, no matter what kind of position they were in, housekeepers, social workers, dietitians, kitchen workers, and went one by one and explained to them the risk. And we actually tried to team up champions that had similar backgrounds that had gotten the vaccine. So actually the first people we vaccinated were people from 5 different areas within the hospital. And then we used those individuals to help us champion the need for the vaccine and the safety of the vaccine so that people would feel more comfortable getting the vaccine. And I think that was very important. And I'm not sure that we've fully succeeded in having everyone comfortable with the vaccine. I think we've certainly made inroads. We made videos, we made presentations, we had town hall meetings to try to have people be comfortable with the safety of the vaccine. And certainly as the vaccine went forward and many millions more people got the vaccine in the original trials, people became more comfortable with it, and more have agreed to have it. But we still have a ways to go, because I'm not sure that every so-called 1A, meaning forward-facing healthcare provider or exposed individual, has yet stepped in to receive the vaccine, and we certainly do want them to.
Thank you. All right, so let's set aside this hypothetical class of 20 years in the future, and let's go to the present. We'll start with Dr. Pellicone and then back to Dr. Garrick. Let's assume you got called to a White House task force or a CDC task force about vaccine design for mass distribution. What have we learned in the last couple of months that you would pass on to people in positions of power about how logistically this vaccine is packaged and distributed? 5 doses in a vial, no, it's 9 doses, no, maybe it's 11, so maybe it should be prepackaged in syringes, maybe it shouldn't, you should draw it up, you shouldn't draw it up, it's in a pallet of 980 doses, no, it's not. If you were going to design a better mousetrap of a vaccine, John, how would you design the thing so we wouldn't have some of the aggravation we've had?
So the talent of my pharmacist notwithstanding that can withdraw 5 or 6 doses from a multi-dose vial in a rapid period of time, there is no question that I would recommend that this vaccine be packaged as a single dose vaccine in a safety syringe, packaged with an alcohol pad, a gauze, a Band-Aid, and a vaccine card. So that you open the package and it's all there, ready for the nurse to administer.
Renee, what would you say?
So I would strongly agree with that. For us, this issue of at the end of the day, we have 3 more people scheduled, and which vial should I open? And then what do I do with the leftovers? Especially if it's a vial with 10 or 11 doses in it, it's become a real issue. And then people want us to track that, and we're supposed to get permission about who we're allowed to give those so-called extra doses to. And the logistics of this have become enormously complex. I would vote single syringe, all pre-drawn with a safety needle, just like John said. And if I had my druthers, it'd be stored at room temperature, but presuming that that can't be done, it'd be stored in a simple refrigerator, and we'd be able to take it out, use it, and move on. The logistics of this have truly added to the complexity. And it would be 1 dose, by the way, not 2, if we could have a perfect world.
I'm sure many people in our audience have read the article that was on the front page of the New York Times about the doctor in Texas desperately trying to use up the 5 or 6 doses that were left over, giving it to people he could find, and then losing his job and being charged criminally for, quote, wasting the doses, when what he thought he was doing was trying to not let dose get thrown in the down the sink. Issues we've touched on.
Yeah, so I just wanted to make one very quick comment. So that physician has been absolutely skewered by the press, but yet people were celebrating the concept that others gave individuals in a snowbank traffic jam the first dose of the vaccine. And I was wondering, how are they going to get their second dose, and who are all those people? So this has been a very complicated situation, and I think the complexity of the administration has certainly added to that.
Well, thanks to Dr. Garrick and Dr. Pellicone for going forward in time with me to 2040 and coming back to the present. Thanks for a very interesting conversation, and I'm sure we'll have lots of interesting questions from our audience when members of the audience type their questions in on the Q&A function. Thank you, John, and thank you, Renee. While we are pleased to provide today's webinar and CME credit for free, it is, of course, not free to put on these programs. They require time, effort, and funds. We hope many of you will consider making a tax-deductible gift where your donation will be used to help offset the costs of putting on webinars like we are offering today. Please consider making your gift by doing it on the phone by calling 914-594-2720 and speaking to one of our development officers. We'll be happy to take the donation, or go to our website, www.nymc.edu/give. Or if you'd like to write a check, put on the subject line of the check, COVID-19 webinar support, make the check out to New York Medical College, and send it to New York Medical College Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking about us and for supporting these programs. And now it's time for our question and answer segment of today's webinar. So let's welcome Dr. Alan Kadish, the president of New York Medical College and the Touro College and University System, to be the moderator of our Q&A program. Dr. Kadish, the floor is yours.
Thank you very much, Dr. Halperin. And thank you everyone for joining us today. We've had actually a huge series of questions from the audience, and we're going to do our best to group them and try to answer as many of those questions as we can. And some of them are complicated and controversial, and so I may ask several panelists to come in and comment on those. So the first question is for Dr. DiCaprio. As we all know, the clinical trials included only adults. So the question is, should we vaccinate 16-year-olds, or should we vaccinate children who are even younger than 16? Are there any data or trials being performed to get those data? And what do you think we should do at present in the absence of data?
Thank you, Dr. Kadish. These are all great questions. And this is definitely an area of intense research. And we will hopefully be getting a lot more data, definitive data on this, especially in the younger populations, probably this spring, early summer. As of right now, the Pfizer and Moderna vaccines are available for children 16 and over. So 16-year-olds were part of that clinical trial. And so some may, identify them as kids, others, the jury's still out. My oldest is 7. So to me, a 16-year-old is a little bit older, but still a child. But they were part of that clinical trial. One of the obstacles of looking at these different ages is the development of their immune system, because there are some variations especially as they get younger. And so identifying that immune system and identifying those parameters is one of the reasons why the trials needed to be delineated the way that they are. As of right now, 16 and up are eligible for the vaccines. Under 16, we're still waiting for. Both Moderna and Pfizer are actively looking into trials and recruiting patients for 12 to 15. They're both looking to enroll anywhere from 2,000 to 3,000. Pfizer currently has enrolled greater than 2,000 children within that age group, and hopefully that data will get released this spring. Interestingly, AstraZeneca, a vaccine that is not yet approved in the United States, they have begun a trial for 6-year-olds and up in the UK. So that will surely be an interesting set of data to come out this summer as well. As of right now, we do need to wait and see what the data looks like, but it will be here soon. Thank you.
Thank you, Dr. DiCaprio. The next question is for Dr. Bakshi. Is there a difference between antibodies produced from having the virus and those generated by a vaccine?
Thank you, Dr. Kadish, for this question. So yeah, so indeed there is a difference between the antibodies that are produced as a result of a natural infection and those which are produced as a result of vaccination. Because right now we are using two vaccines which are approved for use in the United States, Pfizer and Moderna. Both are based on the spike protein. So the antibodies that are generated as a result of vaccination are mostly directed against the spike protein because the messenger RNA is used for the spike protein. But in natural infection, because the body can, our immune system can recognize the entire virus. So there will be a lot of antibodies which are directed against other proteins like the matrix protein and the other nucleoproteins. So it will be a mix. So yeah, so we can differentiate between the antibodies that are generated as a result of vaccination, as opposed to those which are generated as a result of natural infection. And thank you so much for this question.
So the next follow-up question to that is a question of, should people undergo antibody testing after they're vaccinated? So first of all, the clear recommendation is that antibody testing is not necessary after vaccination.
Yeah, so that's correct, because it's not recommended after vaccination that you should go to determine that what the specific, the vaccine-induced immune response is. But in cases, if it is required, there are certain tools that will be available, to test vaccination-induced antibodies. But right now, whatever testing is done, it's basically is done for the infection-induced antibody responses.
Thank you, Dr. Bakshi.
Thank you.
The next question for Dr. Tahara is, why is it that we have a shortage of vaccines? We know that there are many more people who want vaccines, even though there is some vaccine resistance and there's some problem with availability, particularly in underserved communities. There are still many, many more people who want vaccines than are able to get them. And we'll talk a little bit later, perhaps, about some of those challenges. But the question is, why weren't we able to plan better? We knew that vaccines were going to happen. Why couldn't we produce enough vaccine? And I'm relying on your expertise as a systems expert. Why couldn't we produce enough vaccines so that everybody has it?
Thank you for the question, Dr. Kadish. And, it's a great question. And as you already alluded to, it's really quite complicated. So a lot of it has to do with forecasting. A lot of it has to do with the fact that we have multiple players who are producing vaccines. So it's not just one company producing at maximum capacity. So because we have a lot of different, each of the vaccines has different administration requirements. Each of the vaccines, as both Dr. Pellicone and Dr. Garrick referred to earlier, have different kinds of equipment that are needed. And so it isn't as simple as saying, okay, we have the vaccine or not have the vaccine. There's a lot involved in the administration, both on the paperwork, as Dr. Garrick referred to, and also with regarding to the supplies that are needed. Dr. Pellicone discussed, which would be my optimal way of doing it, would be packaging all of the needed supplies in order to administer vaccines, so that you're centralizing and you're facilitating how you need to get the supplies for the administration as well as the vaccine itself. So it's a combination of a number of things. As I said, the more players who come out on the market and the more vaccine that can be produced by a variety of manufacturers make it more complicated to manage, but also provide the opportunity to get more vaccine out. Just to scale up production to be able to produce a new vaccine requires a lot of retrofitting of equipment, as well as then the supplies that you need to make the vaccine. So if your suppliers aren't able to provide you with the quote raw materials to be able to produce the vaccine any faster than you're able to produce it, it doesn't matter how big your manufacturing plant is. If you don't have the supplies, that if you can't get the requisite supplies to be able to produce that maximum output. So it's you know, sort of a domino effect. That's exactly what happened with PPE. That's what happened with wipes and all the other kinds of things. The manufacturers were at their capacity in their production, but their suppliers were shut down for COVID for periods of time, and even a day or a week can really impact your supply chain. So the short answer is it's very complicated. There are a lot of players, and there is a lot of coordination that needs to be done. The more we do it, the better we get at it, the more centralized the information can be. You know, those of you going on the website see that you can get vaccine in Plattsburgh, New York, whereas you can't get vaccine down here in New York City. So being able to do what's called transshipping of vaccine where we have more demand also is very complicated. And as the rest of the panelists spoke about earlier, it's very decentralized, and that can be a blessing, but it also can be a challenge for states that don't have the infrastructure to be able to navigate all of that. I hope that answers the question.
It does. Thank you, Dr. Tahara. It is frustrating, and there's no question that everyone is trying to do the best job they can. I think I would add that a lot of vaccines were under development, and we didn't know for sure which vaccines would prove effective. So as you said, it wasn't that we could pick one vaccine and say, let's everybody gear up to make that one vaccine, because that vaccine might not be effective in clinical trials. And some vaccines have been abandoned in clinical trials because they weren't effective. So it's been a challenge. There's some encouraging news in that regard in the last few days. And the new vaccines that have been talked about perhaps provide an avenue for increasing supply. So Dr. Garrick, the next series of questions is for you. There are several questions about whether having had COVID, getting COVID after your first vaccine dose, or getting infusions of plasma before or after your first vaccine dose, whether any of those things should affect vaccination schedule. So if I get COVID, should I wait for a vaccine? If I've gotten antibodies, does that make a difference? Should any of those things affect vaccination?
Great. Thanks for the question. So there are a number of questions rolled into one there. So we'll go kind of in order. So the first is, if you've had COVID, you can actually finish your quarantine period and then safely be vaccinated. So if you had COVID yourself, the current recommendation is as soon as you're out of the quarantine period, which typically we are following the CDC recommendation for quarantine, although it is different in some states. And we in our vaccine hub use that definition. So out of quarantine, you're allowed to be vaccinated. If you received convalescent plasma, or if you received, which is done for people who are quite ill, the recommendation is 90 days. For patients who have received monoclonal antibody, which is now more common than the convalescent plasma, and I can come back to that in a second, the recommendation is 90 days. So if you were diagnosed with COVID and had convalescent antibody treatment with either the product of Lilly or the product of Regeneron or a combination, you should wait 90 days. And the reason for that is that you just got the antibody. So the concern is that you won't mount a good immune response if you're vaccinated. So that's a 3-month window to wait. The CDC ruled last week that if you're pregnant and decide to be vaccinated and get RhoGAM, it's okay to, even though that's an immunoglobulin, it's safe to go ahead and get vaccinated. And the belief is that you will make and mount an immune response. The question about convalescent plasma versus the antibody is a little murky. Convalescent plasma is still being used, but most of the data suggests that it's not as effective as we had hoped it would be. So that's really been supplanted now by remdesivir and steroids and other modalities rather than convalescent plasma, although we do still use it on occasion. And that answered it. So
it did. What about if I get the first dose of vaccine and now I test positive for COVID? Should I change the vaccine schedule or not?
So we've seen a number of these cases in the hub. We are not, again, if you're ill, We have waited until you're out of the quarantine period from the illness and then vaccinated. It looks like the second dose and the timing of the second dose is not as critical as we thought the first time. So if you get COVID after your first shot, probably you were incubating it when you had the first shot. We're waiting until you're out of quarantine and then giving the next dose, but we're absolutely giving the next dose. And by the way, we're giving it to your other housemates who are sharing quarantine with you, whether if they test negative, we're doing the same thing. And if they're negative, we are giving them the same dose on schedule. But it does look like that timing of the second dose is not as critical as we thought. And by the way, in Europe, if you got Moderna the first time, in this country, it was viewed that you had to absolutely get Moderna the second time. In the UK, they have been actually, because of availability, if you get Moderna the first time, you can wait 28 days and get Pfizer the second time if need be, if vaccine isn't available. And the same has been now ruled by the CDC as being possible in this country. So that linkage is not as mandatory as it had been when the vaccine was first released.
Thank you, Dr. Garrick. So Dr. Pellicon, let's follow up on one of the points that Dr. Garrick made about how the timing of the second dose is not so crucial. One of the things that's going on in the UK right now is that they've actually elected to go ahead and use all the available vaccine for first doses, understanding that they may not have second doses for all those people on time. Do you think that that's something that we should consider in the United States? Or are you concerned that not having a second dose available could potentially impact public health? And others can weigh in on that as well after Dr. Pellicon is done. So
thank you, Dr. Kadish. It's in my conversations with my ID colleagues, the feeling is that about 80% of your immune protection occurs after that first vaccine. I know this question has come up in people who've had an allergic reaction after the first vaccine and whether they should get the second dose. And there is some comfort in that a significant amount of your protection occurs after that first vaccine. The counter argument to that, of course, is that the R0 or infectivity number of this virus is so high that in order to effect the herd immunity that we need, we really want the maximal protection for each individual. And we want that protection across at least 80% of the population. And that's why, if at all possible, you really want to have that second vaccine. So do you think that we need, given the current vaccine availability and the push on everyone to get vaccinated, you carefully weigh the considerations, but do you think we should think about changing policy and not reserving second doses? I would not at this time. All right, Dr. Garrick, do you want to weigh in on that as well, and perhaps some of the others, Dr. Bakshi and Dr. DiCaprio?
Thanks, Dr. Kadish. So at the present time, if we have the vaccine available, I would absolutely give the second dose. My point was that it's not necessary that it has to be exactly 28 days or exactly 21 days. And if you have to push it out a bit, it seems safe, but I certainly would want to give the second dose for the reasons that Dr. Pellicon mentioned. And also, we don't really have the science yet to know that it will be equally efficacious just to skip it altogether. So I would still opt to give it. And I'm trusting that the manufacturers will ramp up enough so that we'll have adequate second dose. And hopefully, as J&J and others come to the market, we'll have more vaccine availability so that we don't have this week by week delivery system that we're currently living with.
But either you, but let me just follow up on that, Dr. Garrick. Either you or the shippers, so to speak, are reserving second doses for people who've had the first dose.
No, we're not. We don't put them aside. We are relying on that we will receive them. So in the very beginning, we were given very strict direction: do not reserve vaccine, put it in the arms. And so far, we have, at least at our organization, we have not had any problem with having second dose available. I know that others have, but we have not. We do a lot of careful math to make sure that we'll have enough available, but we don't say that we're not putting it in the refrigerator and holding it for later. And the state doesn't want us to do that, nor does the CDC. And we haven't had problems. We've always had adequate second dose available. I don't know if that's uniform, but that's how it has been okay here.
And the state is also not reserving it. They're shipping everything out as soon as they get it.
That I'm not sure of. That I can't comment on if they're reserving and holding back. I know we thought the federal government was, and then when Dr. Azar mentioned that, it seemed like perhaps they weren't. So I'm not sure.
So it's part of the confusing interaction between politics and vaccination.
Absolutely. There's been a lot of that in politics in this vaccination world.
So following up on this idea of mixing Moderna and Pfizer, there've been a bunch of questions about the other new vaccines that are not mRNA vaccines. So Dr. DiCaprio, do you have a sense that one vaccine is better than the others, that we should try to pick one vaccine, or that in different circumstances, one vaccine might be better than the others?
It may. I think it's a bit early to tell at this point. We know that as far as the efficacy in terms of most of these vaccine trials have looked at a primary endpoint of preventing COVID-19 disease. There's still a lot more that we need to find out about these vaccines. Do they stop spread? Do they prevent, asymptomatic spread? Is it, they're measuring right now the severity of COVID-19 and or whether they get COVID-19. But they're just not we still have a lot to learn about spreading and asymptomatic spread. And so hopefully that information will get further along, and that will add to the data that we have. Right now, the mRNA vaccines, Pfizer and Moderna, they have a very high percentage for efficacy, 90 to 95%. That is very high. And so from the ability of these vaccines to prevent COVID-19 disease, that is a very strong vaccine. The Johnson & Johnson vaccine, the way that it's being tested is as a single dose. And so that providing a lower efficacy around 66%. While that number may be a little discouraging because it's not 95%, it's important to keep in mind that it is a single dose. And because there's still a lot of information that we need to know, especially as it relates to herd immunity, as well as prevention of spread and kind of stopping that chain of transmission, that may be all that we need. We still don't know, but it is a single dose. It is a different type of vaccine. It is a non-replicating adenoviral vector vaccine. So there may be some people, especially those that have allergic responses to ingredients in the mRNA vaccines, because those are the individuals that we're looking out for, or a history of anaphylaxis with the vaccine. That may be an alternative option for them. But we still...
Could you explain what a non-replicating adenovector?
Sure. So these vaccines the adenoviral vaccine is a viral vector. So it's an adenovirus, right? Many of us get adenoviral infections all the time. It's a very common cause of the cold, especially if you have children. I know I get it almost every year, as do they. But there are many types. And so what they've done is essentially engineered this as just a vector. It's really just a virus. And there's a piece of that virus that they've taken out, many pieces actually, so that it doesn't make us sick. And they've put in a piece of SARS-CoV-2. So plop it right into that nice little virus for us. So it is just an adenovirus that expresses the SARS-CoV-2 spike protein. And that's really all that it is. And it doesn't replicate. So it's very unlikely to cause any problems or any kind of infections that could be related to viral replication, which is very similar to what we see with the mRNA vaccines.
All right, thank you. So we do know that there are, as we heard from some of the presenters, a number of people who are resistant to taking vaccines for one reason or another, even healthcare workers, which is really pretty discouraging. But one of the reasons for that resistance is concern about side effects. And so there have been a whole series of questions submitted about potential side effects of mRNA vaccines. So for both Dr. Garrick and Dr. Pellicone, who are probably more on the front lines seeing patients, what have you seen in the way of side effects? How much should we be concerned about it? And let's talk separately first about anaphylaxis, and then we'll get on to some of the other serious side effects that have been talked about. So Dr. Garrick, you said you've vaccinated 70,000 people. How often have you seen anaphylaxis, and how big a problem has it really been?
So we've probably had one actual case of anaphylaxis and one one unusual reaction that we actually treated as anaphylaxis that in working with the CDC, we're thinking was not. And we've done allergy testing on those individuals, and one of them did indeed have an allergy to the polyethylene glycol, the PEG carrier. So it's more, it seems from the data that it's more common than it is with the flu, but not overwhelmingly common, and relative to the need for the vaccine and the ability to treat anaphylaxis, although it is scary when it happens, people can be treated for it. And the benefit of the vaccine certainly outweighs that risk. The more common side effects are that people certainly have complaints of fever and chills and joint pains and muscle pains. And that's very typical, especially after the second dose for both the Pfizer and the Moderna. It seems it's a little worse with the Moderna than with the Pfizer, but in both cases, it's self-limited. In both cases, therapy with either, in our case, we typically recommend Tylenol rather than non-steroidals. But in both cases, it's self-limited and people generally feel well in a couple of days. We've had some very remarkable local reactions at the arm site that are, some have been very impressive with actually what looks like an old-fashioned Arthur's reaction with a lot of swelling and swelling of the lymph nodes. And again, people get better from it. We explain that you've had a good immune response, but that can be very uncomfortable for patients. Those are really the only serious reactions we've seen. I know that people, certainly in the EUA, part of the EUA work was this thought about whether or not when we create this mRNA and we put it in the ribosomes and we're making this new protein, could it get carried away and could our own immune system end up not being able to control it? And that's why early on in the vaccines, they did look to see if there was vaccine enhanced respiratory disease, et cetera. That has not seemed to be a problem with the vaccine at all. And it does look like it's a very safe vaccine and is not causing overreactivity of the immune system. So we are very comfortable with it now.
So this may seem obvious, Dr. Garrett, but why do you think it's more common after the second dose, the side effects that you described?
I think it's because the immune system is revved up, but I'm not sure of the science behind that, but that's what I think. And so you've already got the immune system going and off it goes. But I'm not sure if that's science or if that's just my thought.
Dr. Pellicone, what's been your experience in terms of serious reactions?
So somewhat similar, we had one young woman who had urticarial and urticarial rash and throat tightening that had to be seen in the emergency department. Interestingly, she had the same reaction to the flu vaccine several years ago. There was some concern about having her vaccinated in the second dose, but she went to see her allergist who cleared her for the second dose. And interestingly, after the second dose had no reaction at all, despite the requirement for steroids and Benadryl when she was in the emergency department. Almost all of our reactions have occurred after the second dose. And just from the workforce perspective, I've actually told my colleagues prepared to work from home the day after your second dose, because I can, from personal experience, those arthralgias and aches and pains can be quite debilitating for about 12 to 24 hours.
So in addition to the side effects that the two of you have described, there also have been cases where people have reported deaths shortly after receiving the vaccine. I'll start with the two of you and then perhaps get some input from the others. In particular, in Scandinavia, there was the suggestion that there was a cluster of deaths after receiving the vaccine. Do you think that this is related, obviously, with tens of millions of people having gotten the vaccine? Unfortunately, some will die. And so is your impression that any of this is related to vaccine administration, not only in your own experience, but in looking at data from others? So Dr. Garrett, do you want to start with this one?
Sure, thank you. So, it's so emotionally easy to say, oh my goodness, we gave a vaccine and we had a horrible side effect and it must be from the vaccine. The one that came to mind for me was the physician who had developed ITP. So I actually looked at that literature because, like a week or 10 days after he got the vaccine, he developed severe ITP, which for those of you who aren't physicians, is an immune-related loss of platelets. And he ended up actually succumbing to that. And there's been a lot of study about the incidence of ITP and the incidence of complications. And it turns out that ITP happens and that if you vaccinate enough people, the overlap of those two events will occur. And the belief is that it was not related to his vaccine at all. despite the early immediate thought, oh my, we got the vaccine, this must be a side effect. Same with Guillain-Barré. That story is still out. There were a few cases of Guillain-Barré in the early trials of both COVID and Moderna. And there was thought that, this vaccine is going to be associated with Guillain-Barré. Right now, at least we have been working with the CDC because of our anaphylactic-like reaction. And their current belief is they do not believe that the Guillain-Barré is more common with this vaccine. So I think we always have to be really careful, get the data, look at it thoroughly, look at the incidence of the events that are occurring, and then better understand, are these things linked? The only one that seems to be more common so far is that anaphylaxis compared to other vaccines does seem to be a bit more common so far with these, both the Moderna and the Pfizer, than with other types of vaccines. But again, I would never use that as a reason not to get the vaccine. It's still very uncommon and treatable, and the benefits of the vaccine far, far outweigh that small risk. Because having lived in the hospitals with lots of COVID, I'm sure that Dr. Pellicone and I agree it's a disease that you want to do everything you can to not get and to avoid having our society inflicted by it.
So one further question on something that the two of you both mentioned, which is taking Tylenol to relieve some of the symptoms, Tylenol rather than nonsteroidals. Is there evidence that either of those could interfere with the immune response? And is that why there's some hesitation about administering them? And what about pre-administration before you get the second dose of vaccine?
Yeah, so we have been recommending not using nonsteroidals pre, and I don't know that it's hard data. It's the same idea of not being on any kind of immune modulator if you can avoid it, and it is a nonsteroidal, and the concept has been if you don't have to take it, don't. And the same is true after. Right now, the CDC is saying, I believe it's okay to take either Tylenol or Advil post. People have responded fine to Tylenol, so we've preferentially used that as long as you don't go over 4 grams a day. But I think it's probably safe to use Advil after, but we've simply been recommending Tylenol because it's easier and we try to be consistent in doing that. I don't know, Dr. Pellicone, what you folks have been doing.
Exactly the same thing. Our first recommendation is to use Tylenol. We don't pre-treat the patients. And if they really insist that their symptoms require the nonsteroidal, then we tell them it's safe to use.
So one of the things that I've heard from some allergists is that the concern about pre-treating is not only related to the immune response, but also that you could potentially delay symptoms of anaphylaxis past the 15 minutes in which we observe patients. And so there seems to be a pretty good consensus against pre-treating with either nonsteroidals or Tylenol before receiving the vaccine. And you've heard what our experts have told you about treating afterwards. Dr. DiCaprio, quick follow-up question for you regarding side effects. Are you concerned that there may be unexpected long-term side effects from mRNA vaccines that we might not see with other types of vaccines?
Oh, you're going to put me on the spot here, Dr. Kadish, aren't you? The $1 million question that everyone is asking. And I wish that I had an answer. And I don't. I think something to be hopeful for is that we are very close to the 1-year anniversary of the start of the phase 1 trials with mRNA vaccines. And so, as we approach that end of March period, which is right around the corner, those individuals who had initially volunteered to get those first doses of the Pfizer and Moderna vaccines, they will be assessed, and their data will be collated and will slowly become available, as will all of the other patients that in that phase 1 and 2 and 3 as they come along. So as we get closer to the spring, we will have at least annual data, data over that 1-year period to see if there were any long-term effects. I will preface, though, that many of those people who were in that phase 1 and early phase 2 were healthy individuals of a certain age range. And it wasn't until later in those trials where older individuals, especially those with some pre-existing conditions, were added. So hopefully we'll start to see. But just given the nature of the mRNA and what we're seeing so far, it's unlikely. I don't want to say that it is absolutely, no, we're not going to see long-term effects of that, but that's why phase 3 is typically a minimum of 2 years, and so we're just gonna have to wait and see, unfortunately. Thank
You did a very well. Good. It was a very good answer, given that you felt like you were put on the spot. So. So, Dr. Bakshi, before we talk about vaccine resistance, one other sort of a basic question for you. And we've heard a little bit about the clinical data, but a couple of our questioners have expressed concerns that the mRNA vaccines seem to target only the spike proteins. So is that an advantage or a disadvantage from your point of view?
So spike protein, actually, it's a very important protein from the perspective of the virus as well as for us, because for virus it is important because it is required for its attachment and entry. So so that's why, and it's in us, actually this is the target for antibody production, and this is also the target for the vaccine production. So I think targeting the first point of contact, which is like when the virus is contacting our cells, and if we can eliminate that, would be the best strategy for any vaccine. And so that's why targeting spike protein, I think it's a smart strategy. But at the same time, as we go along and learn all about these variants, and if because of the selection pressure, the virus is mutating spike protein and it's no longer a feasible target for vaccine development, then maybe we have to look for other targets on the vaccine. But that will come, at a stage, when we have developed herd immunity, because right now we have not faced this problem. Right now, what is going on is these variants are being generated, and they are evolving, and most of these mutations are in the spike protein, and the virus is getting selected for its increased transmissibility. But right now we have not faced the problem of herd immunity. So when all of us have circulating antibodies against spike protein as a result of natural infection or vaccination, then this will add another layer of pressure or selection pressure to the virus. So now the virus will evolve to escape the antibody mediated responses. So that's where, this actual question will come: is the spike protein is a good target, or do we have to go for a broader target, so that we can target like all the variants, as we are going for flu, because like this broadly neutralizing antibodies or universal vaccine kind of a thing. But we have not arrived at this stage. So we are right now dealing with what is at our hand right now, that this virus is mutating only, and the spike protein is the major target. And later on, we'll have to see that whether we have to change our goalpost. Like we have to move our goalpost right from like spike protein to other proteins.
Thank you. That's still a work that's evolving, although we're hoping for continued good news. And as you pointed out, there are reasons to think that targeting the spike protein will be very effective. And as Dr. DiCaprio said, the response rates to the mRNA vaccines targeting the spike protein have been probably better than most people expected.
Right.
So, Dr. Garrick, there are a number of questions about what you can do after you've been vaccinated. And so one of the specific questions is, okay, you've got two sets of friends who've been vaccinated, they want to get together. Do they still need to observe social distancing, wear masks, not hug each other?
Yeah.
What are the recommendations, and what do you think one ought to do?
It's such a hard question, especially after a year of, elbow hugging. The vaccine's not perfect. So the concern has been that even though we've gotten vaccinated, the possibility is that we won't be immune. So I think the current recommendation is to play it as safely as you can. And if you're outside your current sphere of influence, that you should continue to mask. So obviously, most of us aren't masking at home and are seeing our loved ones that hopefully, if they're our age, have been vaccinated. But outside of that, at least for me, I'm still wearing a mask. And in part because if I were unlucky enough to be one of the 5% that doesn't achieve immunity, I wouldn't want to spread it. So, and the other issue is that now that you're immune, theoretically, until we really know, will this prevent sharing of the virus? even though you yourself might be immune, you could be asymptomatic and well, but still have the virus and still shed it to others who may not yet have achieved immunity either. So I've been trying to be very respectful, and outside of my little small, what do we call them? The envelope. Outside of that little group, I'm still masking always. But you're right, it's a tough question.
So Dr. Pellicone, are you getting together? I assume you've been vaccinated since you're on the front lines. Are you getting together with friends? Have you relaxed some of the social restrictions, or what's your approach been?
I haven't been anywhere. No, we actually have not, including family. As Dr. Garrick said, it's a tough question. I do think I would, if you do need to get together, I think it's important to ask the other people, where have you been lately? I mean, if they've been in a small personal bubble where the statistical risk of virus is low, then sure, I think you can get together and maybe you can take the mask off if you've been vaccinated. If any one of those people is employed as a healthcare worker in an ICU on an everyday basis, the risk of nasal carriage could be so significant that it wouldn't be worth the risk of removing the mask.
Right, that's great. So the last question relates to some of the things that we've talked about earlier, which is vaccine resistance, and particularly in some underserved communities that there's a high level of resistance to vaccines. And we've heard today that most of those reasons for reluctance really aren't data-based, that the vaccines really are safe, and that getting herd immunity publicly would really make a difference for all of us. And as we've heard, we've still got social restrictions, even if you've been vaccinated, unless we can get everybody clear of the virus. So I'll start with Dr. Tahara. From a systems point of view, what do you think we can do to convince people who are reluctant to be vaccinated to get vaccinated?
Well, in public health, we have an opportunity now, especially since people know what public health is. Through COVID, there are a lot of folks who really don't know what it is that we do. I think we can just do better messaging. I do want to say this is, I was reading through the questions. This is a really great question, by the way, and one that people, and I get asked by my students, and we get asked all the time, what can we be doing better? I think that efforts to vaccinate in the communities is a much better option where we can. There are concentrations of people in underserved communities, and I think that we could do better to bring the vaccine into the communities to do that. I think that there are a lot of untapped resources. We can be working with community centers, senior centers, libraries, other places where people in the community actually go that are neutral, that in fact could attract people. So I think we need to communicate, yes, the vaccine is safe. We need to communicate the numbers of people who look like you and me and each of the community members who have been vaccinated, so that they say it's not just a number, but there are faces associated with that. So I think it comes down to a lot of messaging and then making it easier for folks to do that. As I said, from a systems perspective, that means really figuring out ways to be and administer that in the community. And you've seen some examples of that in New York State. There have been some faith-based organizations that are vaccine administration sites. As long as you still have the public health and the medical community there to do all that needs to be done, equivalent in terms of observation and in terms of administration and safety, I think that those are the things that in fact will help roll this out. We do just need to be better at messaging that the vaccine is safe, and we need to be looking to community influencers who can help get that message out to community folks. The distrust isn't of the vaccine per se. The distrust is from historically from what's happened in medicine. So we need to sort of get over two humps, right? The vaccine itself, as well as the history that impacts trust. And I think that the physicians on this call, as I said earlier, are in fact those people who are in the trust position with their patients, should really work very hard at getting it out and saying, I got it myself.
Thank you. I mean, I think the community-based idea is a really good one. As far as the physicians speaking to their patients are concerned, of course, one of the challenges is that many of the most vulnerable people and the people who are resistant to vaccines don't have a regular relationship with a primary care provider.
Right.
And the role model mentoring idea is a great one, but of course it raises another ethical challenge, which is if basketball stars, Hollywood actors, and TikTok influencers don't qualify for the vaccines, is it okay for them to get them so that other people who are like will see them and be influenced to get them? And we're not going to answer that one now. So listen, I want to thank
Question, right?
I want to thank the audience for great questions and the panel for really bearing with me even when I put them on the spot. So I apologize for that in retrospect, but that was kind of my job. And so I really appreciate everybody participating. And we'll see you in 3 to 5 weeks for our next installment and update, particularly about variants and vaccines, unless something miraculous happens and COVID goes away, but we're not expecting that, unfortunately. So I look forward to seeing all of you again in the future, and thanks for participating and thanks for your questions. Have a good day.